Good morning, everybody. My name's Paul Leon. I'm actually a registered nurse, and I guess one thing good about age, one of the few things of aging, is I've been doing this a long time. I've been working with unhoused about 25 years, and so I'm like a bad penny. I keep showing up. And so one thing that I heard today, which was really exciting for me, I know Latina said at the beginning, which was so perfect, is that it's so siloed. So, when I started 20 years ago doing street medicine, I drew up a little like basketball picture, and I said, what would I like to have with the street medicine team? I was a nurse, and then I thought I needed maybe a nurse with some psychiatry background, and I needed a benefits specialist. That was my dream. And here I hear Dr. Shea and the home team. That was what I was dreaming about 20 years ago. I was like, wow. Because I knew working with the homeless at that time, that's what they needed. You couldn't just give medical. That mental health was so important. But also housing. And you'll see that through those 20 years, about a year ago, I started looking at how many lanyards I had. I had 820, literally. I'd been to 820 conferences. I was on the board of National Health for the Homeless twice. I'm a senior fellow with AARP twice. Like I said, I'm just like one of those bad pennies that just keeps getting recycled. And still, sadly enough, the problems are exactly the same and have gotten worse. So in those 780 conferences, I keep hearing the same thing. We have to collaborate. We have to work together. And one of my first times working in Orange County with street medicine, it was with Dr. Chow. We went out. The healthcare agency head, who became the head of the healthcare agency, went with us. A pharmacist went with us so he could fill all the pharmacy, the same exact program. And I remember somebody came to us and said, hey, you better not, you're making all the other nonprofits mad. And I go, why? And he explained to me, it wasn't like a fireman, when you're fighting a fire and another division or group comes and helps you fight and you're going, oh, thank God, another unit comes to help us. He goes, homeless is not like that. He goes, when you go to help somebody else with homeless, they say, no, this is our group. Don't be coming in our neighborhood. We're helping these people. And I think sadly enough in those 20 years, that's what I found out, that people were so territorial and they didn't work together. And I think not only policy, but not being able to integrate services were critical. I think that put us back 10 or 15 years. So now I'm so glad to see so many people just starting to collaborate and really integrate and partner. It was so great to hear the home team partnering with a lot of different hospitals, nonprofits, all different types of people, because as you can see, that population which is just booming, we don't need to tell you the problem. You can see the problem. And even more, which is really just staggering on two ends. Most of you probably know the fastest growing population of homeless is seniors, senior women. In some of the shelters that we ran, we had 80-year-olds in those shelters, 80-year-old women in shelters. And we ran shelters that were 400, 500 people in them. And significant amount of the people were over the age of 65. And if you want to see how bad this is nationally, all you have to do is Google any city. Just put it in there and say homeless deaths. I was just playing around with my phone and just saying, I wonder if it's still that bad. I did Cedar Rapids in Iowa, and it popped up 4 people died last night of ODs and one got beat to death with a hammer. You could do that for any city, by the way, any city. It will pop up. Just put homeless deaths, and it'll pop up. So we don't need to talk about the problem. We need to look at solutions. So through the experience, and again, we started with street medicine. That was a great question. How do you make that sustainable? And Michael was right on with housing. Is at the housing point, 15 years ago, we put a lot of people in housing, but they fell out, after 6 months, 8 months. They just couldn't maintain that apartment. So that's exactly the answer. The answer is having people wraparound services that are actually in the housing. So 15 years ago, I started a nonprofit in my garage. It was an MBA project. And it became the 10th largest nonprofit in Southern California. We were the largest recuperative care in the nation. And I'm sure a lot of you heard of it. It's Illumination Foundation. I left there to try to take that model and flip it. Because although we were doing great work, we had hundreds of people in medical respite. The best numbers I could really push out were 18% of people that got into permanent supportive housing and staying. So when you're building a recuperative care that's $15 million, health plans and investors aren't going to be excited to see that you're spending $15 million, you're only connecting 18% to permanent supportive housing longer than a year. So here's what we did. Next slide. So that first slide will just show you, we started consulting when I left Illumination Foundation. I thought, well, we'll show people how to do things. I'm not a consultant. I realized that right away. We are providers. And so what we did was we thought, let's go around California and the US and let's work with the community-based organizations and show them how to run a nonprofit and do those services. That was really difficult because nonprofits, Orange County, I'll give you an example, there's 4,980 nonprofits and 90% of them are under $100,000 or $100,000 annual budget. That is really difficult to scale a nonprofit, to work with CalAIM, insurance companies, and to really be effective. So what we did, we decided to really incubate 3 nonprofits. And so one is Encompass that does housing, one is Whole Person Care that does medical care, and the other one is the Leon Institute. And that's the other thing, when you're really old, you get to name stuff, but it doesn't mean any more money. So the Leon Institute answers the question that we had, again, that Michael had, was what do you do with workforce? Most of the nonprofits we talked to, they were saying, wow, we'd love to do this. We'd love to really work with CalAIM, but we don't have the staff. And so we thought, okay, that's another thing that we have to really look at is workforce and start training workforce, psych techs, community health workers, LVNs. And so that's kind of how the 3 all work together. I can tell you it is extremely difficult, and the next slide will show you what we tried to do. It's really difficult to get 3 nonprofits and scale them for one, but really to have them work together. And so our whole goal was to integrate the services. And if this model really looks really familiar to the home team because it starts with street outreach. It goes to either a navigation center or recuperative. We called them micro communities, but then permanent housing. This is a continuum that I'm really excited to see that a lot of people are starting to use because it's just not one stop. It has to be really integrated, and you have to have that continuum that people can go along. The interesting thing about this is that with the Illumination Foundation, we were able to fund this without CalAIM. We had funded this individually, and we were profitable, even though we were a nonprofit, because that's a misnomer. We made money, and we could fund this whole continuum. When CalAIM came along, and if you know anything about CalAIM, it fit all these pieces. So now we can take an individual, we can fund them the whole way through, because we used to bill for all those services. So we were the pilot program for whole person care and health homes. So when CalAIM came along, we were going like, oh, perfect, now we got funding. So we did really well, but other nonprofits did not. And the reason why is they didn't realize how to blend that funding to be able to have that whole continuum. And so I'm not sure if any of you saw the Kaiser report that came out on the usage of CalAIM, but it's 100,000 people, I believe, that they have enrolled into CalAIM. And most of those are segregated. Like you'll have them in ECM, you'll have them in housing navigation, little bit of recuperative care. So if you said right now, if you ask somebody, they would look at it and say, CalAIM's not working. However, I believe in the next 2.5 years, because it's a pilot program, it will work. So the next slide. One of the things that, and again, the home team talked about it, is the integrated services. It is really hard to integrate services, because you can imagine if you were unhoused, or even if you were partially housed and a senior, to be able to move somebody through that continuum is really hard. If you have to hand a patient or refer them to another entity, it takes a lot of work. Just think about you when you're referred to somebody else, trying to make those phone calls, and the connection is difficult. So we saw people fall along all the way. They'd fall through those gaps. So those 3 nonprofits that I showed you, they all work together, they meet together, they share employees, and that integration is all the way through, from street outreach to all the way to home. Next slide, please. So one of the areas that we saw, and I said we were going to flip that, is, traditionally you go outreach and then you try to refer them into housing or perhaps a hospital. What I learned in that 20 years is, why not flip it and start at home? So start with the permanent housing. Housing first, obviously, most of you have heard about. But our thought was, let's do the services in the home, right? Let's start at home and put a recuperative in an apartment building. Instead of having them come to recuperative care, have the recuperative care in their housing site, and then move the recuperative team. And then they're already housed. So we'll see how that works, because when we presented that, a lot of the health plans are still going like, well, how does that work? The state is kind of thinking, how does that work? But we'll show you how we're planning on doing it. We started community care campuses, and these are that same continuum, but with actual services that will go in the whole way. And we'll give you an example of our newest site. I think it's the next slide. We have a rural and actual urban areas, but we are purchasing hospitals and commercial buildings to be able to place those services in those areas. I think you're really ahead of your times, because you're saying, why don't you use those buildings? Well, we started that about 5 years ago. And our newest is, next slide, is Long Beach Community Hospital. So this hospital was available, and when we went to purchase it, people were looking at us like, you are crazy. It's sitting on a fault. No other hospital would take it, because you can't use acute care. It's thousands and thousands of square foot. It's 100 years old, but it's set right in this incredible community. So it's kind of like my wife does. It's perfect, I'll take it. So we took it over in January, and this is our initial plan. But see the 32 permanent supportive housing? We're hoping to raise that up to 150 to maybe even 200. I hope nobody's from the city council here in Long Beach, because they don't know that yet. But we're going to wrap it around the hospital. But that is, to us, that continuum. and that patient can move through there and then live there. The next slide will kind of show you the phases, but as you can see, and again, if you know CalAIM, you can bill for all those services, and that's what we've been doing. Like, we can bill the client the whole way through. The next slide. So one thing when we talk about partnering, I think it's really open to talk to everybody you can and see if that partnership fits. And Mercy Health and Gene, I want to thank you so much for putting on this conference. And again, now I have another lanyard to add to my collection. But seriously, the difference is when I talked to Gene, and he was looking at coming in Long Beach because the pharmacy will get there, the thing that struck me is that he wasn't saying, I'm going to open a pharmacy there and we're going to live pharmacy to a captive audience. Because we do outreach, we do permanent housing. He was already thinking, what else can we do? Like, what out of the box type things can we work with pharmaceuticals to be part of that multidisciplinary team? And I can tell you, we had worked that out already with the Illumination Foundation because we could see a person on the street, order their meds, find them a housing unit, whether it's recuperative or permanent, and their medications would be there before they even got there. They'd usually be waiting for us. And we knew where they're at, so we can just renew those medications so they didn't run out. So we're looking at commercial buildings. Right now, there's 255 hospitals for sale. If you haven't noticed, hospitals aren't very popular. And being a nurse, and I was a bedside nurse, ICU, ER nurse, when I first started, the length of stay was 9 days. That's how old I was. You were there for 9 days. You know what it is right now? 0.5. I was joking around the other day. I think you can get a drive-through colonoscopy. I know you can have a baby pretty much drive-through because my daughter just had one. So it's just like, bam, you're out of there. So if you're looking at where we're going, because we don't need to look back, we know the problem. Where we're going is the fact that everything is moving towards community health, public health. Everything will be done in the community. So for homelessness, when someone asks, what do you think, where are we going? I think we have to shoot way in front right now. AI is an example, perfect example. We're working with Google on a program to have that robot do some of the stuff we could do inside the hospital. Different things that we have to look forward to, and of course, we know it's housing. When you ask anybody about if you could have a magic wand, what would you do? And it's more housing. That's the key. You have to have more housing. But to do that, you have to have policy. And people would criticize me when I was with the Illumination Foundation because I raised a lot of money. I raised millions, hundreds of millions. And the private sector is just untapped. When we can change that narrative to have them understand that we're working. Can you stop my 2 minutes? I'm getting a little choked up here. I don't want that to add on my 2 minutes. But when you have to help people that can't help themselves, and you convince billionaires that just a little bit of their money can fund programs like Michael's and home teams, just a little bit of bridge money, and that we work together, we can really help the poor, suffering people that are on our streets today.